Annyeonghaseyo. Good morning, everyone. I am Dr. Prashant from Johns Hopkins University. I'll be presenting one of our researches, which is titled Reverse Shoulder Arthroplasty for Glenoid Bone Loss without a rotator cuff tear, a concise follow-up of minimum of 5 years. We have no conflicts to disclose. This has just been published in JBJS. When performing reverse shoulder arthroplasty in patients with glenoid bone loss, one of the treatment options is to rim the glenoid flat without bone grafting. We previously reported upon this at a short-term follow-up with a cohort of 40 patients who were treated with reverse shoulder arthroplasty for glenohumeral arthritis with intact rotator cuff, but these patients had severe glenoid bone loss. In this previous study, we found that the base plate failure rate was 2%. Improvement in patient-reported outcome scores was clinically significantly improved. Scapular notching was present in 19% of the patients. The purpose of this current study was to evaluate the outcomes of eccentric reaming the glenoid using a reverse shoulder arthroplasty for glenoid bone loss in a previously reported cohort after a minimum of 5 years follow-up. We recorded the outcomes in terms of prosthesis loosening, patient-reported outcomes, and radiographic findings like scapular notching. Our patient cohort consisted of the initial cohort of 40 patients. 7 had died, 4 were lost to follow-up, and at a minimum follow-up of 5 years, we had 31 shoulders in 29 patients. A mean age of the patients were 70 years. As per the modified Walsh classification, the patients had a glenoid type of A2, B2, B3, and type C. In terms of surgical technique, all the surgeries were performed by one single senior surgeon at our institute. The prosthesis was a lateralized glenosphere with 135-degree neck shaft angle and a humeral stem which was cemented in all the patients. The humeral stem also had a humeral tray which was inlay type. All the patients underwent glenoid reaming until the glenoid was congruent with the undersurface of the glenoid base plate and targeted with a retroversion of less than 10 degrees and a 10 degree of inferior inclination. In terms of outcomes, our primary outcome was prosthesis survival, which was defined as a revision for any cause, which included base plate loosening. In terms of radiographic evaluation, we noted scapular notching, base plate failure, humeral loosening. In terms of outcome measures, patient-reported outcomes were pain for VAS score, ASCS score, SST score, Booz, Line-Slata, and SF36 score. We evaluated the clinical significance of the improvements based on the MCID values which are published in the literature. We also recorded the range of motion in these patients. At a minimum of 5 years and a mean of 84 months, we found that there was another base plate failure in the cohort, which took the overall survival rate to 94%. The cumulative incidence of base plate failure thus was 5% at 5 years and 10 years. The scapular notching was found in 19% of the patients. In terms of pain, function, and range of motion, all these at the final follow-up had statistically and clinically significant improvement from pre-operative to final post-operative follow-up at midterm follow-up, which is at a minimum of 5 years. So this is one of our patients from the cohort. As you can see here, at the end of 6 years, he's having pain-free range of motion, and he was able to return to all his activities of daily living. Such kind of results can be expected with glenoid reaming without using a bone graft or metal augment, even in cases with severe glenoid bone loss. So in conclusion of the talk, for patients with osteoarthritis, glenoid bone loss, and intact rotator cuff, reaming the glenoid flat has excellent survival and clinical results at a minimum of 5-year follow-up. Further studies are needed to determine whether these results are sustained over the long term and what is the limit of bone loss which can be addressed with this particular technique. From Johns Hopkins University, we would like to thank you for your attention, and I would like to thank Korean Shoulder Elbow Society for having us here. Have a good day and be safe.